Welcome everyone to this Dialogue and Directions program organized by the PCOS Society of India. This program basically talks about the newer guidelines which have been established in 2023, and they are labeled as the International PCOS Guidelines, which have been revised after 5 years after being first published in 2018. There have been more than 38 to 39 organizations, professional organizations, which have been involved in this entire agenda of preparing the guidelines. It's been a huge mammoth task, and it had been brought to all of us through the support and through the hard work of many experts in the field. I'm happy to let you all know that the PCOS Society of India has also been part of these guidelines, and I have enjoyed my discussions with all the experts in the field. So today we have with us one of the professors who chaired one of the groups in the guidelines, and he's Professor Joop, who will enlighten us on what has changed in the current guidelines in the diagnostic algorithm of PCOS. Professor Joop is a professor and head of the Division of Reproductive Endocrinology and Infertility Department of OBGYN. He is also the Erasmus MC. He's with the Rotterdam Erasmus MC Hospital in the Netherlands. He's president of the AEPCOS Society, chairman of the Guideline Development Group of Diagnosis and Screening. This is just a very brief CV, but I would like to introduce to you a man who's been an authority in the field of PCOS. He's the one who has been having immense amount of interest in the field of PCOS. Earlier it was more related to the different aspects of PCOS, the different problems which can occur with PCOS, the cosmetic concerns, the infertility, etc. But now his focus is more on the genetics of PCOS. The focus is more on long-term sequelae. What happens to PCOS women as they grow older, and what is the effect on their quality of life? And this is something the professor has been working on through his center in Rotterdam, which has been the basis of the Rotterdam criteria, as you know, and which were first established in 2003. He has been teaching as a teacher for the Bachelor of Medicine and Master of Medicine programs in his university, which is one of the largest university in the Netherlands. And this is bringing to you Professor Joop. It's not Joop, it's Joop, I'm sorry. That's the correct way of pronouncing it. And bringing to you this wonderful expert on this field. I'm sure you'll learn a lot on what changes have been made in the algorithms of how we diagnose and manage PCOS patients. Today, the focus for Professor will be on what are the changes which have been brought about in 2023 and what are the long-term effects we see in women with PCOS. So welcome to this program, Professor Joop, and we are very happy to have you here. And may I request you to start with your presentation, which will be followed by a discussion on the subject. Thank you.
Thank you very much for this kind introduction. So what I plan to do in the next 20 minutes or so is to highlight a few of the things which we changed in the new diagnostic algorithm. And the algorithm looks like this. You start with asking the patient whether she has irregular cycles. That's everything which is less than 21 days interval or more than 35 days interval. And you should assess that at least 2 years after menarche. Because most of the girls then, around 90%, will have developed a regular cycle. Then you assess clinical hyperandrogenism, as it is shown here. You do that using visual scales, like the modified Fred-Mengolwig score. And there are different cutoffs for different ethnic groups, which are all presented in the guideline. If somebody has an irregular cycle and has clinical hyperandrogenism, your diagnosis is already there. If there is no clinical hyperandrogenism and she does have irregular cycles, then you test for biochemical hyperandrogenism. do that preferably using the newer methodology like mass spectrometry. If your free androgen index or your testosterone level is higher than what you would expect in a normal population, that's also a problem. Of course, we have no normative data yet. But if your free androgen index is above 2.9, for instance, or your testosterone is about above 2, using LC-MS/MS, then you have biochemical hyperandrogenism, and then your diagnosis is also set. If you have no clinical or biochemical hyperandrogenism, then you have to resort to ultrasound. And ultrasound is an issue because we know that ultrasound is not done in a protocolized way all over the world, but it depends very much where you are, whether you get a good report or not. And that's why we also looked already in the 2018 guideline, but there was not that much data available yet, but it was in the 2023 guideline. And there we can have as well, instead of this PCOM assessment by ultrasound, you can measure a single AMH level. And there are cutoffs for different AMH levels, but there again, we need cutoffs which are age stratified and are very specifically defining cutoffs per different age category. So if your AMH is elevated or you have PCOM on ultrasound, then your diagnosis is set as well. So what about these cycle characteristics? I have summarized it again here. There is quite some evidence for that. Normal in the first years post-menarche as part of pubertal transition and ovulatory cycles, I would say. Between 1 and 3 years post-menarche, it should be less than 21 days or more than 45 days. After 3 years post-menarche to perimenopause, it should be less than 21 days interval or more than 35 days interval, or less than 8 cycles per year. That's about how we define irregular cycles. Most girls will develop an irregular cycle within the 2 years post-menarche, so when they have reached an age of 2 years gynecological age. Adolescents with irregular menstrual cycle, the value and optimal timing of assessment and diagnosis of PCOS should be discussed with the patient and their parents or guardians considering diagnostic challenges at this life stage and psychological and cultural factors. I make life easy for myself, I must say. If I see a mother, which I know already for years, which has PCOS, she has an older daughter which has PCOS, and she's now visiting me with the younger daughter, and the younger daughter has hirsutism, and she has irregular cycles, then I think she has PCOS. And so although you might not assess her by ultrasound, or she is refusing to take a blood sample, then still she has PCOS. If you are in doubt about the diagnosis, re-evaluate them, let's say 4 or 5 years later. Biochemical hyperandrogenism, I said already, use the methodology like I pointed out to you. It's free testosterone, or it's a calculated free androgen index, which you should use. And you should use that based on data which were gathered with LC-MS/MS. There is not that much of added value of DHEA, DHEAS, or androstenedione, as we also formulated in the guideline. But in case there is a clinical hyperandrogenism and you don't have an elevated testosterone level or a free androgen index, then look at whether there are DHEA or DHEAS levels or androstenedione levels are elevated. But they don't, in most cases, add anything. Laboratories should use validated, highly accurate tandem mass spectrometry assays for assessing hyperandrogenism in a biochemical sense. Clinical hyperandrogenism use visual scales like the modified Fermi-Golgi score, and professionals could also recognize that female pattern hair loss and acne in isolation without hirsutism are relatively weak predictors of biochemical hyperandrogenism. A modified Foreman-Gorby score of 4 to 6 should be used to detect hirsutism, depending on ethnicity, and acknowledging that self-treatment is common and can limit clinical assessment. The problem, of course, is the 4 to 6, because in some ethnic groups it is 4, in others it is 6. Southeast Asians might have a score which is 4 already, and then they have clinical hyperandrogenism. In European countries, Western European countries, it might be something like 6. Ultrasound. Ultrasound is considered that you need the follicle number per ovary is the most effective ultrasound to detect polycystic ovarian morphology in adults. It is also the most effective way in adolescents, but then again, you have, most of the time you have to use the transabdominal approach, which has a poorer resolution and therefore is not that well suited for this job. Follicle number per ovary, follicle number per cross-section, and ovarian volume should be considered also as accurate ultrasound markers for PCOM in adults, but preferably use follicle number per ovary. PCOM criteria should be based on follicle excess, so follicle number per ovary, follicle number per section, and ovarian volume enlargement. And of course, what I told you already, a lot of these assessments are not done according to a fixed protocol. It depends very much how you are insured, where the gynecologist is sending you, whether he is doing the thing himself or whether he sends you away. And keep in mind that more than half of all patients PCOS around the world are treated by internists, and they don't have a reasonable fast access to ultrasound. They have to send their patients away. AMH, serum antimullerian hormone, can be used for defining PCOM in adults. There's quite a bit of evidence for that. Serum AMH should be used in accordance with the diagnostic algorithm, noting that in patients with irregular menstrual cycles and hyperandrogenism, an AMH level is not necessary for PCOS diagnosis. So if you have the two first ones here, then you don't have to assess PCOM. We recommend that AMH should not be used as a single test for the diagnosis of PCOS. There is some literature pointing in that direction, but there is a lot of heterogeneity between studies. There's a lot of inconsistency, and there is a huge risk for bias in these studies. And that's why we not claim this yet, that it could be used as a single test for the diagnosis of PCOS. I touched upon these things. Serum AMH should not be used in adolescents. Why is that? Because in adolescents, levels are generally increasing instead of decreasing. And so we really need new reference data in normal populations as well as in PCOS populations. And we don't have them at hand at the moment. Be aware of some effects which are summarized here, that peaks between the ages 20 to 25. Body mass index has an impact on serum AMH because they are lower generally. Hormonal contraception and ovarian surgery may suppress AMH levels, and it depends also a bit on the menstrual cycle day. This was shown in a very nice paper of Scott Nelson. Here you can see the nomograms on the right-hand side if you are on oral contraceptives, and then you see that indeed the curves for oral contraceptives, that's the green one, are generally lower in terms of AMH than the orange ones, which are the women in the control group. There's no effect in the range of copper IUD. Hormonal IUDs do affect it slightly, not that much. And if you're on no birth control, then you see that the lines perfectly align. Another thing which was shown in that study, and that's particularly important, is that especially low levels of AMH are much more influenced by, for instance, a combined oral contraceptive pill, implants, and vaginal rings. and progesterone-only pills, compared to the more higher levels depicted here in green, and the orange levels, which are around the median. So take into account that especially patients with very low levels are mostly affected by these contraceptive measures, and you should repeat the measurement, as far as I can see, at least something like 3 to 6 months later, and then you will see that levels are generally quite a bit higher than you intentionally thought that they would be. These are the ROC curves of all the different assays, and as you know, there are different assays around for AMH. That's a bad thing because there's no international reference, so you can't compare these assays with each other because they have different cutoffs, they have different techniques in which they measure AMH. This is something which we did very recently in a paper which is going to be published very soon in GCEM. We looked at a cutoff, in this case for the Beckman assay, the Beckman-Coulter assay, which is 5.5 nanogram per ml. And we looked at all the women which were above that level. And interestingly, I was quite surprised that I see that this cutoff lies around the 50th percentile, not somewhere around the 90th or 95th percentile. So everybody in red here has PCOM and has an elevated level of AMH. The interesting thing is if you look at the green levels, which are below the 5.5 cutoff, then you can see that even in this group, there is still some 34% of patients which do have polycystic ovarian morphology, because in these patients, we assessed the ovarian morphology in every patient, because this is done in my big cohort, which is now something like 2,500 patients. And so we did this for all the 3 other assays which are generally used, and they show similar pictures that in the green area, which is probably designated as the ones which do not have PCOM based on a certain cutoff of the assay, figures range between 20 and something like 34% of patients in the green areas which still had PCOM. So a new thing is the cardiovascular risk. We reasonably think that there is quite a bit of evidence which shows that women with PCOS are having an overall increased risk of cardiovascular disease. And that's definitely true in premenopausal women. Whether it leads to hard endpoints like stroke, cardiovascular disease as a compound measure, or coronary heart disease, that has to be seen, because we are talking about risk factors and not about real hard endpoints. All women with PCOS, regardless age and BMI, should therefore have a lipid profile, and if it's elevated, let's say sufficiently adequate measurements should be taken to keep this down to acceptable levels, because this is an additional risk factor for cardiovascular disease. And all women should have a blood pressure measured annually, I would say. That's at least what I advise my patients. And if they are hypertensive, they should be treated much earlier on in life than it's regularly done. Impaired glucose metabolism and type 2 diabetes risk. We know that the type 2 diabetes risk and gestational diabetes risks are 2 to 4-fold higher than women with PCOS. And so healthcare professionals should be aware of that. And regardless of age and BMI, women with PCOS have an increased risk for impaired fasting glucose, impaired glucose tolerance, and type 2 diabetes, which is, of course, a kind of continuum. And glycemic status should be assessed at diagnosis in all adults and adolescents with PCOS. So really measure a fasting glucose and a fasting insulin, please. Glycemic status should be reassessed every 1 to 3 years, based a little bit on the individual and additional risk factors for diabetes. Healthcare professionals, women with PCOS, and other stakeholders should prioritize preventive strategies to reduce type 2 diabetes risk. Last but not least, this is my last slide, ethnic variations. We address ethnic variation as well. Healthcare professionals should be aware of the high prevalence of PCOS in all ethnicities across the world regions. It's a fairly constant phenomenon what we see. We are doing 2 large studies in sub-Saharan Africa. There, the incidence is basically the same, ranging from 10 to 13%. Healthcare professionals should be aware that PCOS prevalence is similar across world regions and ethnicities, but might be higher in Southeast Asian and Eastern Mediterranean regions. And that might be driven by an increase in, for instance, heavier women. That might be a driver for that. And risk in relatives is also a new aspect in the guideline. And that has to do with the fact that fathers and brothers of women with PCOS may have an increased prevalence of metabolic syndrome, type 2 diabetes and hypertension, and cardiovascular disease, actually. And so the question is that related to the PCOS of the proband, or is that related to a kind of common sharing, which is done in these families between 2 completely independent things, like metabolic derangement leading to cardiovascular disease and type 2 diabetes, and independent from that PCOS? Because most of the genetic studies nowadays at least point in the direction that BMI might be an elicitor of the phenotype, because if you increase in weight, then the phenotype all of a sudden becomes obvious, but it's not the cause of PCOS. And PCOS, in return, is not causing obesity. Having said that, I would like to finish with, this is the international guideline. There are 2 very important papers about that. That's the guideline itself, with all the recommendations in there. There's the technical report, which is 5,700 pages, and it's reviewing all the evidence which is there and which we've sorted out during the last 2 years. If you go to Monash PCOS, you can download the guideline there, as well as the technical report. Also advise your patients to look at the leaflets which we make for patients to inform them about PCOS. There is a very nice app, Ask PCOS. Ask your patients to download that. They have to register. We don't do anything with this registration, just knowing from which country you are downloading the app. And there's also a lot of information available for GPs and for all people which are falling in the Anglo-American regions. There is also a course to be taken from the website, which is CME accredited, and you can really take that course in just a few hours, and then you're completely updated about the new guideline. And having said that, I would like to thank you for your attention, and happy to answer any questions.
Thank you very much, you, for this very clear talk and presentation, which I'm sure most of our delegates have enjoyed. I have a few questions for you. You mentioned that that in a PCOS woman, if her BMI is high, she's likely to have a low AMH. Is it common? Is it only for PCOS women that you find that, or even for the non-PCOS women?
Well, it's also in non-PCOS women the case, I think, but not that much large series which are looking at that. But it's especially the case in PCOS women, as it is also if you stratify them according to BMI, for instance, and you look at normal weight, overweight, and the most heaviest women, then you can see that also LH levels are different. Androgen levels are generally different. They are higher, although LH levels are lower. FSH levels are lower in women with a higher BMI. And the same holds true for AMH. And that's probably due to the fact that, let's say, there is some intra-ovarian factors which are causing this. And probably the arrest in the ovary of a woman which is heavier is probably much more affected than in women which have a normal weight.
And we know that oral contraceptives lower AMH. I think it becomes a very important history taking, which we must do with our patients. And I find that many infertility clinics depend only on the AMH to advise a patient on whether she needs to, think about going in for her own eggs or whether to offer donor eggs. I've
Yeah.
seen that happening many times. But when we stop the oral contraceptives, within a few months, say 3 to 6 months, it starts coming up, especially in the younger women. So, any reason why that happens? Is there too much of suppression of the ovary and that's causing the reduction in the AMH? Is that the answer?
Yeah, well, what you see is that in that study from Scott Nelson, they looked also at antral follicle counts, and antral follicle counts were following the same thing, which we know, for instance, for women which are the perimenopausal transition, there you see the same thing, AMH goes down, and antral follicle count follows that. It's also the same with the oral contraceptives, although I must say the suppression level is something like 25% less if you use COCPs. It's even more if you use, let's say, things like progestogen only or depot preparations. They might give something up to 64% depression of your AMH levels. And Duru, I think it is the same as what you see with as soon as women have been treated successfully for their hirsutism in their face, for instance, because you put them on the oral contraceptive pill, then you suppress androgen levels by increasing SHBG levels.
Yes.
What you see in these women is if you treat them then with laser for facial hair and hair in this area, then a lot of these women think, oh, that my problem is solved, and they stop the pill again. And
Yes.
thereafter, you see that in half a year or 1 year, hair growth is starting to come back. So apparently, androgens which are suppressed for quite some time, they recover again, and it's probably the SHBG which goes down, and thereby increasing the free androgen levels. That's basically the same. So contraceptives generally suppress something in the ovary, which is reflected in numbers of follicles and also in AMH, of course, then. And probably what I learned from that is that it's probably happening in the smaller follicles, because we always look at when we find a patient with a very low AMH, which is unexpected. We also do an ultrasound. We look at the antral follicle count, and if there's disparity between the antral follicle count and the AMH level, then you see quite often that if you wait, that the AMH level will recover. So there is kind of a little bit of disparity between the two things. They are not going hand in hand anymore. And whether that's also the case in PCOS women, we don't know that. But we see there, again, a similar trend. And keep in mind that the effect is much larger in low levels compared to higher levels. And in PCOS, we are generally dealing with high levels.
Yes, that's
so
true.
the effect in PCOS is probably less.
But that's what it gives a very false sense of insecurity to women when they want to get pregnant and they get their AMH.
Definitely.
And they feel, oh my God, what's happened to me? I must go quickly for an IVF or do whatever I need to do to have a baby.
Yeah. And it's not only happening in your clinic. I saw a patient last week, which is a midwife. And I saw her half a year ago. She had an AMH of 0.3, which is dramatically low for her age. Then we redid it. It was a little bit higher, 0.46 or something, which was still far below the first percentile for her age, because we have percentiles for normal women. And then I saw her back about a week ago. And why did I do that? Because I was looking at her AMH, which she had determined. It was 3.5, which is perfectly normal. It's P60 for her age.
Absolutely.
But she had a period of half a year in which she was very sad about the message I had for her. So we really should take care of that we are not jumping into conclusions there, because that might be really devastating for some people. And of course, she was very happy. She said, I'm happy that you were mistaken, but I have felt quite a bit guilty about what I did to her in the 5 months before that.
Yes, no, I agree with you that I think this is the message which should go across, that please note the histories prior to the women coming to you with a low AMH and see whether they've been on any medications which are causing suppression of AMH. And maybe does the level of AMH matter in which part of the cycle you do the AMH? Does it matter too much?
Yeah, it matters, and we published a recent paper about that, and especially what you see, but that's happening in all the assays, but at different levels. The higher your follicle number is, if it's somewhere above, let's say, the total follicle count for both ovaries is more than 50, you see that AMH levels basically stay the same, and that happens in all the assays. And in some assays, it's around 40 follicles. In other assays, it's around 50. In the NCHLAB assay, that's the best assay actually in this sense, because it parallels quite long. But all the assays diverge from each other, and some are measuring higher levels, some are measuring lower levels, and they do that in the low ranges and in the high ranges. In the mid ranges, they perfectly parallel each other. And that makes it difficult to compare these assays because there's no international reference. So you can't compare actually different assays nowadays with each other. And so you and I are interested in low levels and high levels because that's where patients come with.
Yes.
And there it depends very much on the assay, which implies that, yeah, you have to make your own reference set for normal women in your own clinic, which is of course ridiculous because that's a huge amount of work. And
Yes.
how many normal women do you see on a daily basis? Most of our patients have fertility issues. Most of our patients have other issues. So that normal women are not coming to our clinic. Yeah, we are very much relying on large cohorts, which we are initiating, like Generation R. Generation Rotterdam is that. There's Generation R Next, in which women are assessed already pre-pregnancy. Yeah, that's something which is really important. But yeah,
Need
we
to do.
really need an international reference.
Yes, absolutely. So coming to the long-term sequelae, which we discussed the three important parameters of cardiovascular risk, the diabetes, mellitus, and hypertension. I think these are areas which we need. Ethnicity. I think we need to look at what really is happening to these women as they get older, and what are the likely problems they're likely to have. So question is, at what stage do you think we need to assess the woman whenever she comes to us for all these conditions? Like, it's been a part of my practice. If any woman I suspect or have confirmed or diagnosed as PCOS, I like to run all their tests to know what is their baseline so that I can guide them further. What is your practice and what would you recommend?
Well, what we do is the initial assessment has all these things in it. So we measure blood pressure, we measure height, we measure weight, we calculate the BMI, we measure waist and hip circumferences. We do a complete lipid profile, including HDL, LDL, and cholesterol. We do a fasting insulin and a fasting glucose. And if there is anything aberrant in there, we start immediately trying to cope with that. So if there is hyperinsulinism and the glucose levels are still quite okay, even after an OGTT, which we have done, then we start with metformin most of the time. And I believe that the GLP-1 agonists are going to provide us with some, let's say, good medication to deal with that problem as well, also in women with PCOS. The only thing you should avoid is that they get pregnant during that treatment. So you should really take care of contraceptive measures, because otherwise Novo Nordisk is going to sue you instead of you them. That's one thing. How often do I repeat that? Depends a little bit on how the patient is doing. Is she making some advances? Is she losing 5% weight, for instance, or 10% weight? Then we keep on tracking that. In case everything is normal, in the beginning, let's say from 20 years onwards, we do that every 5 years. And then we repeat the whole initial assessment, the screening, which we call the cycle oligomenorrhea, amenorrhea screening here in the Netherlands, and we repeat that. And a lot of academic hospitals do that in the same way. As far as cardiovascular risk is concerned, the problem is, of course, that we studied cardiovascular risk in PCOS women here in a large cohort, which we are following up in Rotterdam already for, I think, more than 30 years. So the oldest women which were in there were 80 at the time when we assessed them. And they are assessed every year, and every 5 years, all kind of other things are done. So we had coronary artery calcification. We had plaques in the carotid arteries. We had all kind of other parameters assessed. And we had 200 women which were diagnosed at age 20 in that group with PCOS back in those days. So we followed those up, and they had a similar cardiovascular and type 2 diabetes risk as the women which were in the control group, which were not having PCOS. And that was a fairly large group, something like 5,000 women or so. In the beginning, I thought, that's reassuring. So they have not a higher risk in hard endpoints, because we were dealing with hard endpoints, not only with hypertension, but with hard endpoints like stroke, like myocardial infarction, or a compound measurement of cardiovascular disease. And in all of these, also the survival, the 5-year survival, was the same in PCOS women compared to controls. What I realized later on is that if you look at the genetic makeup of women with PCOS, they have better DNA repair genes. And so all these non-communicable diseases have as a kind of, let's say, bottom line layer, which makes them more susceptible for that, DNA repair. And so if you are not well suited to repair your DNA, you have a higher chance to develop diseases like type 2 diabetes, cardiovascular disease, and neurodegenerative diseases. Women with PCOS are very well equipped to repair that. So actually, they should be better than the reference population, I think. And we looked at DNA composition in women with PCOS and women in the control group. And indeed, in the control group, there was a normal distribution, and that distribution was skewed to the right-hand side in terms of better DNA repair in women with PCOS. So really, there is something to gain there. Because if they would be better off at the end of their lives, then that might also explain that they are better equipped to live longer, because they generally enter menopause later. And I always thought in the past that was due to the fact that they had higher AMH levels. It's a genetic driver which does that. And so to summarize, I think these data which we produced should not mislead us in a way that we think that it's okay because they have not an increased risk. They do have an increased risk, and they have already delivered a little bit in terms of health, because they should have been at a higher level compared to the controls, taking their genetic makeup into account.
But have you been able to determine any particular genetic sort of cluster in any of your particular ethnic populations?
Yeah, well, we are doing that in a collaboration with the US and China. And actually, what we found is that there are 3 clusters, and in the Chinese collaboration, we found about 4 or 5 clusters. But there is indeed a typical metabolic cluster and a typical reproductive cluster. And I think the metabolic cluster is particularly at risk to develop these sequelae later on in life. We didn't look at that yet, but we are on the verge of doing that. That's one thing. The other thing is Also in the Chinese population, we found such a cluster. And we redid the analysis which Andrea Donaif did in her NIH patients. So those are only patients with either hyperandrogenism or irregular cycles. We redid it in our complete Rotterdam cohort, which was diagnosed according to the Rotterdam consensus criteria. There we found basically the same distribution. And we could also look at a little bit more of these parameters. And what we could see in the reproductive phenotype, antral follicle counts were higher there. All kind of other parameters which were related to reproduction, like FSH levels were slightly lower, LH levels were slightly higher in these patients. If we looked at the metabolic phenotype, they had higher cholesterol levels, they had higher levels of lower levels of HDL, higher levels of LDL. So it fits into that picture. And we are struggling now with the indeterminate group or the intermediate group or the group which is not falling into a specific cluster. Interestingly, that group is driven by androgens only and FSH beta. So that tells you something about their sensitivity for FSH, I guess. But we really need more data and more women in these clusters to really substantiate that third group. But there is definitely a metabolic phenotype and a reproductive phenotype, which is also has a different genetic background, which makes it very nice to see that genetics and the phenotype are in line with each other. And probably what we until now called PCOS is a mixed bag of different diseases, which are going to cluster into different clusters in the near future, I guess. And whether I will experience that during my, let's say, productive lifespan, that's questionable. But definitely in the near future for younger people, there will be something which is coming on. So PCOS will fall apart in different diseases.
Yes. But is there any specific genes you have identified where you see some kind of a mutation or some issues? Because we
Yeah,
are not.
well, it's more the genetic variants which are causing that. And you have variants which are very well capable of doing something, and you have a similar variant which is doing that in a less sophisticated way. And so it depends very much on the way to get to get some insight into this is genetic risk scores. And we are developing these genetic risk scores in the different groups. But I think groups are until now too small to do that very, let's say, reliably. And so, but that's also something which is coming up in the near future. We saw it already in menopause. We have about 300 variants in menopause in 500,000 women. In PCOS, in the International IPCOS Consortium, I'm one of the board members of that consortium. We have only something like 25,000 women in there, which is it's 1/20th of what we had in menopause. And so the number of SNPs which we identified until now is similar. It's down to 20 or 25. And the androgen receptor isn't there. FSH beta isn't there. The FSH receptor isn't there. But those are variants. So they are not really mutated. Those are variants. And some of them are more sensitive and others are less sensitive.
Okay. So there's quite a bit of genetic work happening as I see, but yet we still don't have one diagnostic test which will tell us this woman has PCOS
No.
and this is the risk she's going to carry. But yes, we know that menopause is associated also with metabolic syndrome. PCOS is associated with metabolic syndrome. So do you find it that after menopause, these PCOS women are getting into a bigger mess when they have got metabolic syndrome earlier during their younger days? And when they get menopausal, does it get worse or does it stay the same?
Well, that's a good question, and we don't really know that. So going back to the data we have, they are at the same level as a reference population, but they should be better off. The only phenotypical feature which remains after menopause is hyperandrogenism. The androgen levels are still a little bit higher compared to controls, even post-menopause. But the risk factors remain, of course. And so nobody knows whether we should treat those. But what I generally see is I see quite a few women which are around their 50s and they have a diastolic pressure of 95. And most GPs will say, we have to remeasure again. We don't treat that. But probably you should treat these women with antihypertensive medication. And that might reduce their risk in the long run, probably. And there's nothing to do. There are no arguments to think against that. So I think keep on track of these women. The big problem, of course, Duru, is in the Netherlands, I talk to the GPs and I say, you should screen these women. You know what they say? Yeah, but Professor Laven, you come with screening for diabetes, screening for metabolic syndrome, screening for hypertension. And a lot of other specialists will tell us as well, we have to screen for colon cancer, we have to screen for prostatic cancer. We are not screeners, we are general practitioners. So we are, as we call it in the Netherlands, the house doctor, which is very much acquainted with the personal situation the patient is in, because he is very close to her natural environment. So what we need is screening institutes, probably in the Netherlands at least, and I don't know how that's in India, but probably you're facing the same thing, because a lot of these GPs will say, listen, I'm not going to do that. And that poses quite something on your patients, because if you would visit me every 2 or 3 years, that's something like 380 euros, which is $400 every time you visit me. And if it's only a short visit, how are you doing? Oh, I'm fine. I'm still alive. My blood pressure is fine. My insulin is okay. That's quite a bit of money. And people are much more taking that into account nowadays. And that's really a threat for the general health of the population, I guess.
Yes, I totally agreed. Actually, there have been some of my patients whom I've been following up for a long time. I think more than 200 and 250 patients, and reached menopause now. And I find a higher percentage of cardiovascular risk in these women, especially the ones with metabolic syndrome, which started earlier in life and now post menopause. Many of our Indian women put on a lot of weight after menopause. And they think it's part of menopause, which I don't think it is. But their metabolic syndrome gets worse. And invariably, if you get their carotids done, the ultrasound screening or the scores of the calcium scores for the coronaries, you'll find that they are high, and then maybe you may be able to prevent problems. So when you send these patients to the cardiologist, he'll do an angiography and find there are blocks, and they've been able to prevent cerebral strokes and coronary artery problems. So in short, I think as gynecologists, probably we need to be aware that these are the issues which are where women of PCOS who have already got problems, probably at menopause, even otherwise at menopause, we are screening women. Maybe these women need more frequent screening, or making sure that they remain under control and make sure that they are taking their medications. There's a lot of lifestyle you have to guide them. There's a lot of advice you have to give. And these are the things I think is important for us to do. There's one more question.
On the other hand, Duru, sorry to interrupt you, but what I said a few minutes ago is I wrote an editorial about this in 2019 in Fertility Real, and it was called Family Ties. And it was about the paper from Bülent Yildiz, which is a good friend of mine from Turkey. And he summarized the data in the large, he pulled together all the family cohorts with informative trios, which are around the world available. And he showed that fathers and brothers had higher AMH levels when you had a sister with PCOS.
Yes.
But he also showed that triglycerides were higher, cholesterol levels were higher. All these values were, let's say, shifted to the non-favorable side, and well within the normal range still. And what I took from it is, it could be, although genetic studies nowadays don't show that PCOS is not a cause of cardiovascular disease. But they are probably in an other way intertwined with each other. That in these families, they are very much more susceptible to develop PCOS, but they also have a different susceptibility, which is completely independent from PCOS, for cardiovascular disease, type 2 diabetes, or whatsoever.
Yes. That I agree.
That will still be the case. Although, if they are, let's say, sequestering together, then it's then we have an opportunity as gynecologists to see them early on in life, and then we really should assess these factors in these women as well. Although it's not primarily our duty, I would say, we should really do that, because they might have an advantage of that anyway.
Absolutely. And the other question, last question I have for you is that you may be seeing Indian women in your country. Probably some of your patients may be of Indian ethnicity. Do you find any difference in those women compared to your local population?
Well, if I look, I was prepared for that question. Yes, I see quite a few. Rotterdam harbors 256 different ethnicities. We see a lot of women with Suriname Hindustanic backgrounds, but also women from Indian countries. And I must say that the Indian ones are most of the time expats. So they have a better lifestyle. They have socioeconomic status, which is higher. They're most of the time not overweight or heavier. But the Hindustani women, they, well, without an exception is a little bit too strong, but let's say 90% of those has already hyperinsulinemia. They have elevated blood sugar levels. But we know that group has been selected out through the years, and they have a higher incidence of perturbed glucose metabolism, or insulin resistance, or type 2 diabetes. And most of them will develop type 2 diabetes anyway, because if you ask them, is there anybody in your family who has to have type 2 diabetes, then nearly the whole family has already developed it.
Right. So what would you recommend for Indian women who have PCOS on how we can either prevent the future generation from developing PCOS, and how we would manage the PCOS women today?
Well, I would say screen them much more frequently, and maybe according to the guideline on a yearly basis. And as soon as they develop hyperinsulinemia, we should put them on medication.
Yes.
And I don't know whether metformin is the best. I think it should be GLP-1 agonists. And they completely reverse the whole process within just a few months. It's incredible. I'm myself on it for half a year now. My blood sugar is down to normal and was elevated, was 8.6. My insulin was above 100, is down to 60 now. My liver scans are normal. My liver function tests completely normalized, and I lost about 12 kilos. And I'm still I'm not on the maximum dose, so I'm still going strong, I would say. But it's really something which we should not withhold these women from. And they need that. And look at, I don't know whether you know, but we did the largest randomized controlled trial whether lifestyle would be worthwhile doing. And it's in every guideline. Lifestyle, first line treatment. And you know, the results are so bloody poor. Actually, at the end of the day, in my study, 40% dropped out of the study. So they left because they knew that that would not mean that they would have the child. So imagine what that is. So how much the driver for that is. 10% or 20% got pregnant. 40% stayed in the study. And of these 40% of women, which was something like some 80 women or so, which stayed in the study until the end, the endpoint was 4 BMI points lower. Only 1% achieved that. 20% weight loss, was achieved in, or 10% weight loss was achieved in 20% of women, and 5% weight loss in 60% of the 40 who remained into the study. So it's not that easy to lose weight.
No.
And that's also why we said this weight stigma, step away from that weight stigma, because things like every pound you increase go through the mouth, that's bullshit. That's really not what we should convey to these women. They increase in body mass faster than controls do. They are not capable, as controls do, in losing weight again. So I really see quite an era for the GLP-1, the other antagonists which are coming on, like tirzepatide, and we should not withhold that medication from, especially patients like PCOS patients. They deserve that.
Absolutely. So that's
And I would say you could already start before they get pregnant. If you could reduce the weight considerably before pregnancy, imagine what you could do for then you could do a lot of good work there.
absolutely.
Until recently, I was still on call for OBGYN. Half a year ago, I did a C-section on a woman which had a body mass index of 65. And she said to me in the operating theater, that was before pregnancy, because I gained a few kilos during pregnancy. and that's really something. And they end up as a lot of complications. She had a son which was small for gestational age. Everything you could think about, she developed during pregnancy. So if we really could help these women prior to pregnancy and see what we do after pregnancy again to keep them down on that weight. But I think these medications will be around and readily available. It's not now the case, of course, but they will be readily available in the next few years or so.
No, we have them available in India currently, but they are very expensive at the moment, beyond the reach.
I know.
The oral medication is available, is not available, I think, the injectable. So one of them is available. Anyways, the last question is, at what age have you seen PCOS youngest individual? 8 years, 9 years? You don't diagnose PCOS, but you feel that probably this child is likely to become a PCOS.
Yeah, it's what I tell most of my patients. If you have a daughter or a son, bring them back around the time that they are ready for that. And the mother should determine when they are ready for that. Because we know, of course, from the international guideline groups, especially the group I was in, that a lot of women around the world told me that they were diagnosed too late. And a lot of pediatricians are very much afraid of diagnosing too early, but that's probably not what patients want. So if we're talking about PREMs and PROMs and value-based healthcare, then we should listen to these patients. And they are saying to us, I was diagnosed too late. The first hurdle I had to take was my mom. The second hurdle I had to take was the GP, and he didn't refer me. And at last I was referred. And guess what? I had PCOS. I knew that already for years, but I was not treated accordingly.
Right. Anyway, thank you so much, Joop. It's been a pleasure talking to you.
It was a pleasure.
For sharing all your expertise and all what directions you have given to our listeners. And on this note, I would like to thank you, the audience, the team at the PCOS Society of India, and of course our support system for carrying out this program is Torrent Pharma with an unrestricted educational grant. So thank you so much for being with us. Thank you.
The pleasure was mutual, and thank you guys for listening to me and being interactive with me. I enjoyed it very much.
Thank you. Thank you so much. Bye-bye.
Bye-bye.